Scientists working in laboratories hope their research will lead to clinical trials to test new treatments. Dr. Dan Halperin will discuss clinical trials and research in immunotherapy for neuroendocrine cancer. Dr. Halperin is an associate professor at the University of Texas MD Anderson Cancer Center in Houston, and he's chair of the NET Multidisciplinary Conference there. He will be moving to Emory University in Atlanta in September to lead their NET program. Dr. Halperin?
Well, hi everyone. I'm Dan Halperin from MD Anderson, and today I have the pleasure of chatting with you about what I think is the most interesting and probably vexing topic in our field, which is immunotherapy in neuroendocrine tumors. A lot of challenges and a lot of opportunities. Here are my relevant disclosures. I think most importantly, we're going to talk a lot about investigational use and focus on clinical trials today. So for anyone who is going to fall asleep after the first slide, here's everything I'm going to say on one slide. The most important thing I want everyone to understand today is that the current state of the evidence really does not support standard use of immunotherapy for most of our patients with neuroendocrine tumors. There's a small minority of folks, I'll show you the special case, where people can fit into some tumor-independent indications for immunotherapy, but that's really a small minority. The second thing I hope to convey is that a deeper understanding of the tumor immune environment may offer us some insights and hopefully offer some new opportunities and new approaches. And then finally, we're going to talk just a tiny bit about CAR-T, which is right on the horizon of investigation. We think this is a really interesting novel approach that has some unique considerations. So as a trialist, we often think about clinical trials as enlightened empiricism. So let's talk a little bit about the moderately enlightened empiricism of the last 10 or 15 years or so in this space. So it actually was 15 plus years ago that Kjell Oberg and his group made the observation that immunity against tumors is somewhat impaired in patients with neuroendocrine tumors. And they actually observed circulating suppressive T cells and difficulty with expanding or activating the immune cells of the patient against some of the targets that were expressed on their own tumors. So they knew something was wrong. And actually, Professor Oberg has been one of the most vehement advocates for the use of interferon alpha, which is in many ways the original immunotherapy in clinical oncology. And you see here a couple of representative studies, again, almost 15 years apart, where folks have tried to see what, if anything, interferon might offer. You'll see a small randomized trial on the left where the addition of interferon couldn't significantly improve patient survival. And then to the right, you see a larger and more recent study nicely demonstrating that interferon and bevacizumab were similar in their effect on patients, but unfortunately not telling us what that effect might be, whether it was actually adding something compared to placebo or not. So it remains, as I say, a bit vexing, but we have yet to understand whether interferon as sort of a prototypical immunotherapy is adding much for our patients. And it's not something that is routinely used in clinical practice most of the time. And so I use that as a segue to start thinking about the cancer immunity cycle. And it's a complicated slide that we're not intending to go through in detail, but rather just to point out that folks much smarter than me have thought about how we can break down the process of developing an immune response against a tumor. And what I would point out is just that interferon nicely fits into one of those boxes. It fits into box 2 here. It helps with the presentation of antigens as folks are developing, ideally, an immune response. And so we can start to think about the various therapies that we might have at our disposal and that we might evaluate as targeting different elements of this cancer immunity cycle. And in fact, you may notice as we move through the presentation, I'll try and highlight how the various therapies that have been tested may target these different steps along the way as we try to turn on or unleash immunity against a neuroendocrine tumor. So here we have sort of the first, I would say, modern therapies of typical immune checkpoint inhibitors. And unfortunately, the title says it all. These have been rather disappointing and I would say in some cases heartbreaking. What you'll notice here, I've described the objective response rate and progression-free survival in a fairly large study of pembrolizumab. I would describe it as fairly similar to an expensive placebo. Response rates less than 5%, progression-free survival of 4 months and change, 3 to 5. This is right in the range of what we see in the placebo arm of a lot of randomized trials in this field. No clear relationship with the expression of what we would think of as the target, PD-L1, and just generally fairly disappointing. And on the right, you see a similar agent, spartalizumab, targeting the exact same spot. That's the red box you'll notice in that reference tumor immunity cycle. And again, other than maybe a few folks with lung neuroendocrine tumors, not a lot of activity that was seen. And of course, we think of immunotherapy. If some is good, more must be helpful, right? So let's target 2 different nodes and combine ipilimumab and nivolumab. This was the DART study in the cooperative groups. And unfortunately, for patients with well-differentiated neuroendocrine tumors, you'll see here the lower intermediate grade, complete response rate was 0 and partial response rate was 0. So again, really not showing necessarily a lot of clear and convincing evidence for benefit in our patients now that we're hitting these couple of nodes together. But thanks to a number of projects that were supported by NETRF, we started to understand a little bit more about why that might be the case. And what I would point out is that those nodes that were just targeted with ipilimumab and nivolumab, they tend to be particularly helpful in patients whose tumors have pretty rich immune infiltrates, things we would call hot, if you will. And work led by Matt Kulke with a NETRF pilot award about a decade ago helped us to understand that these were actually, in fact, cold tumors with generally scarce lymphocytes or immune infiltrating cells, giving us some sense of perhaps why it might not have been quite so helpful to be pounding on the T cells that were just nowhere near the tumor, trying to get them to respond. Now, additional work supported by NETRF by Dr. Kim helped us to understand a little bit more about why these tumors may be so cold. And she helped us understand that, in fact, some of the proteins that make these neuroendocrine tumors so hypervascular may also contribute to exclusion of the T cells. And you'll see here on the left some data from humans showing us that, in fact, tumors with high expression of these pro-vascular proteins decrease the presence of T cells, and also the patients do less well. And shifting to the mice on the right, what she helped us understand was that if you block that process with an antibody, you can help increase immune infiltration and help mice live longer, better, healthier, and we hope more fulfilling lives. Interestingly, work by a totally separate group on the other side of the world suggested something very similar, which was that if we block the hypervascularity in a similar tumor model, we can increase immune cell trafficking, increase expression of that target PD-L1, and then block that PD-L1 to help mice, again, live longer, better lives and increase the immune infiltration. Now, this seemed like a really good idea, and we performed a clinical trial to see if combining VEGF blockade with a classic checkpoint inhibitor would be helpful. And unfortunately, the results were not what we were hoping for and expecting. We saw response rates on the order of 15 to 20%, and progression-free survival durations on the order of 12 to 15 months or so, quite similar to what we might have seen with a standard VEGF inhibitor like potentially bevacizumab itself. It's worth noting, of course, that this was a study that was based not only on the observations supported by NETRF that were seen over the last couple slides, but our own preclinical data that were supported at the same time as Dr. Kulke's work. Now, we weren't alone in going after these targets, and a couple of years later, Dr. Strasberg's group at Moffitt saw very similar results with an analogous combination of pembrolizumab and lenvatinib. So showing us, once again, going back to that tumor immunity cycle, that even hitting these 2 nodes of trying to improve T cell trafficking through the tumor together with checkpoint inhibition with a PD-L1 or PD-1 inhibitor wasn't enough to help patients respond against their tumors. Now, from there, while I may have dashed everyone's hopes for a bit in demonstrating how ineffective what we thought reasonable immunotherapy approaches might be, let's pause for a moment and talk about that minority of patients where we may be able to find some benefit. And so what you'll see here is an old but I think relevant figure demonstrating the mutational burden of many different kinds of cancer from, I believe, the Cancer Genome Atlas. And what you'll find is that tumors that tend to be responsive to immunotherapy, tumors that tend to be hot with rich T cell infiltrates, all actually congregate over on the right side of the left-hand figure. So cancers like melanoma, lung cancer, stomach cancer, Tumors where the mutational burden is high, we tend to see more responses, and we think about that as being because there are more targets that are new or neoantigens for the immune system to respond to. Now, I've highlighted in red the neuroendocrine tumor patients. You'll see they were called carcinoid in those days. And you can see that actually it's a log or two less in terms of the tumor mutational burden. And this is something that's been reproduced several times. That includes in our own data over on the right, just referencing that bevacizumab and atezolizumab study. But what I use those data to illustrate is not just that the tumor mutation was generally low, but that there were a few patients, you'll see that high blue dot and a couple of others, above the classic 10 mutation per megabase threshold that we think of as independently predictive of potential benefit from immunotherapy. Now, the reason we think that is there was actually a study of pembrolizumab in patients with tumor mutational burden over 10, demonstrating a reasonable response rate in the 30% range, but I think more importantly, that patients whose tumors responded tended to do very well for prolonged periods of time, and it was actually difficult to observe how long the patients would live because they would do so well. So the point of that is just to illustrate that there is that small fraction of patients, probably further into the course of their disease than those studied in that left-hand figure I showed you a minute ago, who may have an elevated tumor mutational burden and may benefit from immunotherapy as a result. And that is a tumor-independent or tumor-agnostic indication for pembrolizumab, rather than one specific for patients with neuroendocrine tumors. Now, finally, let's turn to CAR-Ts. And these are relatively novel for us in the solid tumor space, but really the concept here is that we will engineer T cells so that they target something very specific. And so in order to do that, we're going to need to figure out what they should be targeting. Now, I'm going to distill years of someone else's work into a single slide here for the sake of time, but this is work by Professor Sinjun Hua at Penn, who was supported by an Accelerator Award in 2018. While I'm not showing the figures of figuring this out in llamas, apparently, originally, they were able to determine that there was an actionable target, CDH17, that was overexpressed on NETs and potentially targetable with an engineered T cell. And in fact, much of the work that he describes is in the process of engineering the targeting of the T cell specifically to CDH17. Now, what you'll see here in humans on the left is that surface expression of the target, the CDH17, and what's worth remembering about this as a target is that normal cells don't have it on their external surface where it can be seen by the immune system, but rather it tends to exist to hold cells together and therefore is privileged or hidden from them. And in that pie chart, what you can observe is that it was roughly half of the neuroendocrine tumors surveyed at that time that demonstrated expression, although I believe that has a predilection to tumors in the gut, which will bear out in a moment. What you see over on the right, though, is the really cool stuff where they engineer the T cell, and then you start to see in the cool colored photomicrographs the purple immune cells finding their way into the tumor, but not the normal intestines or small bowel or colon, and not really having an effect on the normal tissues, just the tumor. And then in those curves, you can see that the T cells are actually expanding in the blood. That's the lower right. And I'm just going to remind you of the difficulty that patients' T cells had expanding to tumor antigens back in the very first slide. And then in those tumor growth curves above, you can see the way that they were able to kill the cancer, and we would hope prolong the mice's lives with these CAR-Ts. And so this was quite exciting, and in fact, the CAR-T was acquired by a company that is right now opening a clinical trial of this drug. Now, these CAR-T cells and these studies can be a bit complicated. We have to be very careful about monitoring for appropriate toxicities, and they're rather complex to do. But it's really exciting to see something entering the clinic, coming truly from the bench to the bedside. And so as I alluded to, what you can see here is that after the dose level escalation, there's an expansion into patients with a few different tumor types, including midgut and hindgut NET, as I said, because this particular target has a predilection for the gut. So we're really excited to see what we can learn and hopefully help folks with this new therapeutic approach. So, as I said, for anyone who's zoned out for the last 10 or 15 minutes or so, that's fine. Here's all the main points again for you. So I hope that we've convinced you over this time that immunotherapy is really not a standard part of the management of the vast majority of patients with neuroendocrine tumors, other than some very specific cases that we discussed. But that a deeper understanding of what's happening in these cancers hopefully helps us understand why some things may be more helpful than others and suggest new approaches for us to take. One of which is CAR T, which, as we said, is about to launch, looking at CDH17 targeted CAR T cell developed out of work supported by NETRF. And we hope that this unique approach will be helpful for patients, but only time and research will tell. And with that, I just want to thank you all for your time and attention. And again, my sincere gratitude to NETRF for the invitation. Thanks.